3 of our global summit. Today's what we've done up to now. Day one, we focused on the low resource scenarios. We looked at the situations that are common in countries of Africa and other poor countries where fundamentally the systems are in disarray and incomplete diagnosis and treatment is the common theme. Yesterday we talked about the low resource scenarios where the systems are much more likely to be complete and in place but may not be functioning with optimal quality, and where a common theme is downstaging of disease, where there's clearly an opportunity to improve statistics. So having laid out this framework, today we're going to talk about problem solving. How do you actually address this? And by the end of the day, I'm absolutely confident that we'll have this all worked out. That's the beauty of it. What I'd like to do is begin with, this is a piece that was put together at the meeting that Felicia Nall and Larry Shulman organized at Dana-Farber last November. And they had a breakout panel that they asked us to say, well, you know, what are guidelines? How do guidelines fit into this international health care? And I'm going to walk you through what this sub-panel concluded. Because something that we've been clear about is that just the development of guidelines doesn't solve any problems. It's not till you fit the guidelines within a healthcare implementation strategy that it makes sense. So when you look at guidelines, there are different types of guidelines that are commonly out there, and the organization of them will determine what sort of utility they have. So the guidelines that are most commonly quoted, like NCCN and St. Gallen for breast cancer, what they do is they say, well, if you have all the tools in place and everything you ever thought of, how would you put this together in the optimal fashion? So it's a scientific set of questions in this idealized setting that probably none of us actually practice in, certainly not in a perfect fashion. What the Breast Health Global Initiative did starting in 2002 is ask the question, well, what do you do when you don't have all of those pieces? And that resource stratification piece that we've been talking about over the past 2 days of building, how do we sequence this building to try to get towards those idealized guidelines? That work is there. There's a third set of guidelines that we really haven't discussed at all, which has to do with quality. So for example, in radiology, the whole BI-RAD system and quality measurement for mammography is a fabulous example of how to think this through in an organized way that allows you to compare center to see, are you doing what you need to do? These features of the common features are that guidelines need to be evidence-based, they're not arbitrary. Having some type of prioritization framework, that's something that the resource stratification does. But you also have to recognize that they have to be flexible and evolutionary, meaning that the guidelines are not fixed in time. It's something that develops, particularly as new scientific information comes up. So in terms of the guideline process, this is in the middle part of this. We begin with a general framework, and that's what we've done with the BHGI guidelines. But then you have to ask the question, well, how does this apply? How does this apply at a local level or a regional level? And in multiple settings, this is what groups are doing. So people in the Middle East have asked, how does NCCN apply in the Middle East? And there's an NCCN MENA guideline that is an adapted version. But again, we really need to think about quality assurance and process metrics, because if you think you know what it is you're supposed to do, but you do it badly, you're not going to achieve that outcome. So quality is a key issue. So there's the guidelines in the middle. Well, how do we make this real? And what we proposed in this group was that on the top end, if this is going from top to bottom, you begin with a situation analysis. What is it that we have now? And then we move into implementation. And so it's a funnel where you funnel into this trying to spread out. The ministries of health, we were talking about this in the panel yesterday afternoon. The ministries of health, these are the decision makers. They typically are those that are responsible for resource allocation. That's why we have to talk to them. And political will, as Eduardo Kazap was talking about, is a key issue. If you don't have political will, it's probably not going to change. No matter how much wisdom you have, there has to be something that compels the system to go through this. Nobody likes change in particular. In terms of the situation analysis, you need to look at resource assessment. What is it that we have at the medical and technical levels? And that's what we physicians typically discuss or clinicians talk about. But there also is a situation analysis for what do the people think? What do the women believe? What's their awareness? What are the belief systems that you're working in? Because if the women don't participate, you're not going to improve outcome. You also have to consider, as you're doing the situation analysis, who are the stakeholders? Who actually has an investment in making this go forward? So there's the medical folks, there's the public health folks that don't necessarily have the same perspective. We have seen this with the most recent updating of the U.S. Preventive Services Task Force change of screening mammography in the U.S. The clinicians say, I want to start at age 40 and go annually screening mammography because I think one patient at a time, and I believe that I'm going to see that difference. The public health scientists say, I look at it as a population. I think I look at the mean rather than the error bars on this side. And so you can come up with diametrically opposed conclusions looking at the same information. And of course, the advocates are the ones that are driving this process and are part of that political will. At the other end, at the implementation end, we begin with pilot projects. So it's fine to have these guidelines, but you got to start small to see, does this work? I think it's going to work, but if you don't do a pilot project, if we just go out and kind of take a shot at it, you may not get it right. And in fact, probably won't get it right. I think that's how science typically works. So there's the concepts of pilot projects is that they're adapted at a local or regional level, and they need to be oriented towards capacity building. You know, the scientific questions about screening mammography or, how much do we do or self-exam. What do I get with self-exam? We've done a scientific experiment where we tried to extract self-examination in Shanghai to figure out what's the impact. That's a perfectly valid methodology, but that doesn't have anything to do with capacity building. So how do we build projects that will help create increased capacity with the same resources? And ultimately, we then have to look at evaluation. We have to do measurement to see, did we make a difference? And the things that we want to measure are, is it effective, is it feasible, and is it sustainable? We talked about money allocation. If you just send money to a country, that means that when I stop sending money, the project stops. So how do we create projects that are self-sustaining, that go on beyond where we were? And that is the ultimate goal in this implementation. You're leveraging resources. As Julio Frank talks about the diagonal framework, we don't want diseases competitive with each other. There is no advantage in breast disease taking on HIV as a competitor because it's the same infrastructure that makes this work. So how do we maintain a disease focus so that we can solve problems while we have commonality with other groups that have a similar goal? I think that the work of Hope Exchange is a great example of what we're thinking about in Africa, developing specialties to improve capacity overall, not limited to disease. And data collection, we have to collect the data or we won't know the differences. So with that, I would now like to introduce our advocate, Elizabeth Thompson from Susan G. Komen for the Cure, scientific director for this program, is going to be speaking to us about the efforts of Komen.